Hello ladies and gentlemen, I'm here to present a approach to chest pain in the emergency department. This is just a quick review of some of the things you've already covered in Primary Care 1. We're just going to do a summary of these conditions, and you're not really expected to know exactly all the details of management, but just know the general idea and just be aware of these conditions, along with all the other conditions listed in your readings and in the clerkship guide. So this lecture is open to anyone who wants to modify it and distribute it, as long as you attribute the original authors. Now, the differential diagnosis of chest pain in the emergency really breaks down to what I call the really deadly ones and the somewhat deadly ones. The really deadly ones are your obvious ones, like acute coronary syndrome or heart attacks, aortic dissections, pulmonary embolism, tension pneumos, pericardial tamponade mediastinitis, etc. The somewhat deadly ones that may kill if left alone or not treated appropriately are listed here. So we're going to focus mostly on the really deadly conditions. Now, I want to introduce you the paranoid mind of an ER doctor. You're always looking around for anything that might kill or maim your patients. Anything else really can be discharged home. You are looking for these really deadly causes of chest pain, and if these are treatable and dischargeable potentially, or maybe not myocarditis and maybe not pneumothorax, but you get the idea. But you're really looking out for what is potentially deadly to your patients and what you can safely defer management for a later time. Now, a good chest pain history, I'm sure you've gone over this algorithm in your clinical history and clinical skills courses, but this is just a review. I'm going to attach a document that shows an outline of what a good chest pain history is as well, along with this slide. But generally, you should always ask about the OPQRST points, palliating and provoking factors, associated symptoms, risk factors are very important. Every patient you see with chest pain, these questions have to be covered. Now, just going on to acute coronary syndrome, the typical presentation, which is your average middle-aged white male, will have that crushing chest pain that radiates to the left arm, jaw, and shoulder. Unfortunately, most patients aren't the typical demographic that the clinical description describes. Elderly, women, diabetics will have atypical symptoms, sometimes only dizziness. Atypical symptoms are often the rule, and many MIs are silent. So if someone's feeling generally unwell, that could be their anginal equivalent, we call it. Now, risk factors could be anyone above the age of 40, male sex, family history, smoking, cocaine use, especially in young people, truncal obesity, the metabolic syndrome, or diabetes. Now, these are typical patterns that you should know of the distribution of ischemia, and generally ways to spot posterior MIs. You should know when to do 15-lead ECGs. And your cardiac biomarkers are your troponin, which is the most sensitive and specific, your CK, and your myoglobin. This is a graph that shows when your troponins peak, and when your other markers peak. Your CKMB peaks earlier than your troponin, and generally this is the reason why we do serial levels, like every 8 hours or every 10 hours, or at least 8 to 12 hours after onset of chest pain, because as you can see, the troponin peaks after a few hours and plateaus later on. After 48 hours or so. So it's important to always do serial levels of these enzymes. Treatment, which you've already covered as well, is aspirin, heparin, Plavix, nitro, beta blockers, and this kind of thing should be in your brain and programmed, ready to go. Next condition, aortic dissections. This is a very rare condition, and honestly, you'll probably see maybe a few in your career. The ones you'll catch, at least. This is notoriously a very difficult condition to catch. I've personally, in the last, I'd say, 6 years of practice, only seen 2 of them, and both of them survived, thank God. We're going to actually go over one of the cases right now. Now, risk factors that should clue you into this: male sex, hypertension, atherosclerosis, any sign of vascular disease, age above the age of 60, also uncommon things like connective tissue diseases, Marfan's, you'll see like tall, lanky people, any history of vasculitis or recent cabbage. The symptoms include a sudden onset tearing chest pain that radiates between the shoulder blades in the back. That's about 85% of patients, but it can involve multiple locations with migrating symptoms depending on the extent of the dissection. If you have patients who have chest pain and abdominal pain at the same time, you should think about this, especially those with risk factors. People who have chest pain and limb numbness, this should also attract your attention. This is sort of a description of the sort of anatomy and the classes. You should know the Stanford and DeBakey systems of classification for the aortic dissections. 90% will have an abnormal chest x-ray. The three things to look out for, or the four things, is sort of a widened mediastinum, abnormal aortic contour, a pleural effusion, and bronchial deviation. So if you don't see any of these, then chances are 90% chance it's not an aortic dissection. A D-dimer test, it's controversial and neither sensitive or specific. ECG is normal in 31% of cases, and non-specific changes are the most common finding. And your imaging is the most critical test here, and this is something you need to do as quickly as possible once you suspect the diagnosis. And the case that I saw most recently was a 79-year-old woman who had very classic features and the history that I just described, and it was almost a no-brainer in her case. Very few people will have those classic symptoms though, and so you should guide your suspicion by clinical factors and also risk factors. Her physical exam was remarkable. What to do, you should always get ready to get ready for emergency measures, such as get your stat ECG, get your aspirin, your oxygen, get your IV access. You should also check your blood pressures in both arms. In this case, the physical exam showed a BP discrepancy, which even further clinched the diagnosis in our case. That's not present in the majority of cases in dissection. She also was diaphoretic, but not in any distress. She had good air entry. The rest of her physical exam was fairly normal, except asymmetric pulses on the left arm. This is her ECG. Again, as you can see, non-specific sort of ST flattening in the lateral leads. And this was her x-ray. And what do you see about this x-ray? I spy a widened mediastinum here and here. So these are some questions that you could ask yourself. What is a diagnosis? In this case, we think this is an aortic dissection, and our management and medications to consider. First, let's go over the imaging. This shows you can see here sort of the widened aneurysmic aorta here, and this is the descending. This is the arch component. This is the descending component. You can actually see the thrombus here, and the dissection here. Here you can see it again, and this is sort of a 3D reconstruction, and you can see the dissection here. So in this case, there was a Stanford type B dissection, and this is a description of the CT report. The dissection flap begins just distal to the origin of the left subclavian, and it extends caudally down to the level of the diaphragmatic hiatus. So our goals in management are to reduce the BP. The main teaching point is that you need to reduce the degree of dissection, which is governed by the sort of what they call the dP/dt, the amount of pressure applied over unit time over the flap. So if you reduce the heart rate and the BP at the same time with drugs like labetalol, propranolol, or esmolol, you will prolong survival. And in this case, with this kind of dissection, this can be managed medically, and some 90% will survive to discharge. Ascending type, a dissection, is a surgical emergency and will not be amenable to medical treatment, and that has a 1% mortality per hour. Another condition you should know about is myocarditis. This involves inflammation of the myocardium. This often has a viral etiology. Basically, your presentation will include severe chest pain, tachycardia, and perhaps enzyme elevation. So these are just some symptoms. Like you could have CHF symptoms, friction rubs, and ECG changes as described here. The treatment, if it's bacterial, is antibiotics, but usually the mainstay is supportive care, and in some cases you might even need a ventricular assist device, which is an exotic piece of sci-fi equipment which you may never see, but you may see in these kinds of patients. Pericarditis is something you should know about. This is, there's these apocryphal stories about people who send patients to the cath lab based on ST elevation on an ECG, when in reality it was pericarditis. The presentation, the classic features are gradual onset of sharp or stabbing chest pain that radiates to the back, chest, left shoulder. How is this different from ischemia? This is more sharp and pleuritic, as in when you take deep breaths, rather than pressure-like and sort of crushing type pain. The pain is often relieved by sitting and leaning forward, and you can often hear a pericardial friction rub. This is a typical ECG of a person with pericarditis. You'll note diffuse ST elevation, PR depression, and no reciprocal changes at all anywhere. These are just a description of what typical ECG findings are in the different stages of pericarditis. And tests, basic tests. These more exotic tests are more for checking for lupus or for any rheumatologic condition, hyperthyroidism, etc. Most of the time, these pericarditis is caused by it's post-viral or idiopathic, and usually a regular dose of NSAIDs. Even simple ibuprofen, 2 tablets for 1 to 3 weeks is good enough. And if you suspect any other cause, you should arrange for an early echocardiogram. Pericardial effusion or tamponade. Normally, you have about 50 cc's of pericardial fluid, and if you've ever done ultrasound training, you'll always, in many patients, see a sliver of fluid. That's normal. But if there is a buildup of fluid, let's say in a penetrating trauma, you'll have increasing dyspnea, decreased exercise tolerance. You'll have a patient who will start to have tachycardia, low systolic blood pressure, narrow pulse pressure, pulsus paradoxus, and JVD, jugular venous distension, muffled heart sounds, etc., etc. Low voltages on the ECG because the blood is actually acting as an insulator and keeping the electrical signal from traveling up to the chest. And the treatment here is bolus IV fluid to try to fill the heart against sort of the pressure around it, and pericardiocentesis, monitor in intensive care. Pulmonary embolus is another condition you should know about. This used to be missed quite a bit before maybe about 15 years ago, when there was less awareness of this. Quite common in patients who are coming out of surgery before the age of prophylactic and preventative heparin use. We have evolved a number of risk scoring tools to try to identify these cases, and generally the risk factors in these cases are patients who've had prolonged venous stasis, as in people on long flights or in the OR or in beds for long periods of time. Some of the cases we see in the ER are patients who have basically gotten up from 14-hour flights and dropped dead right in the aircraft or in the terminal. And in some rare cases, we've actually been able to bring these patients back with thrombolysis. That's the most extreme example. Patients who have protein CNS deficiencies or hypercoagulable states are more predisposed to blood clots such as this, or patients who've had previous injuries or endothelial dysfunction are more predisposed to pulmonary embolus. The features, usually you'll have a patient with risk factors will have dyspnea, pleuritic chest pain of any kind, cough, quote-unquote anxiety. They may even have a syncopal attack. 50% of them will have signs of a DVT. Massive PE, patients will have hypoxia, cardiac arrest, in the worst cases, such as the one I told you about before, and hypotension. ECG findings, you'll often see a pattern of right heart strain, right axis deviation, right bundle branch block. If you ever see a patient with right bundle branch block as a new presentation and tachycardic, etc., then this should be, up there in your differential. The typical S1Q3T3 pattern that's been described is present in about 20% of cases. The most common finding is a sinus tachycardia. This is a patient with a right bundle pattern and tachycardia, as we just talked about. Wells score is a scoring system device to quantify the various risk factors. And you can go over your patient's history. A positive score generally indicates a need to be extra vigilant, that you cannot rule out cases basically with a negative D-dimer. So score greater than 4 on the Wells score, you should consider a diagnostic test. A score of 4 or less is when you can sort of use the D-dimer. Another test is the PERC rule, which you should be familiar with. Is basically if any of these tests are positive, then you cannot use the D-dimer to rule out PE. The best and most often the used test we use is the CT pulmonary angiogram. It's and the VQ scan and the angiogram are sort of standbys that you can use if warranted. And treatment is usually low molecular weight heparin, IV heparin if you're hospitalizing them, or if surgery is imminent. Thrombolysis in massive PE, those cases with hypotension, shock, etc. Embolectomy in some cases, and in patients, let's say cancer patients who will not survive the next PE, an IVC filter is warranted. This case of esophageal rupture we've already covered in the GI section, but as you know, the features are severe chest pain, subcutaneous emphysema, and macular striad, etc. Basically, it is 100% fatal if not caught. And IV antibiotics, surgical treatment, ICU care, etc. Thank you very much.